We are live.
Okay. So good evening, friends, and welcome to this 34th episode of All India Postgraduate Teaching Program, an initiative from ARCOS. This is a PG program with some difference compared to other postgraduate teaching program because it covers the uncovered aspects in teaching programs like case presentations, journal clubs, OSCEs, and didactics on topics which are not comprehensively available at a single go in a textbook. In the last case episode, we had two short cases, and today here we are with the 34th episode of this series and the 8th Journal Club. In today's Journal Club, the first article would be presented by Dr. Meghna Grandi. She is a final year resident at Arvinda Hospital, Madurai. And the second article is going to be presented by Dr. Anirudh Herur, who is a final year resident at Shantilal Sanghvi Cornea Institute, LVPI, Hyderabad. I'm really thankful, heartfelt thanks to both the mentors, that is Dr. Naresh Babu, who is a Chief Veterinary Services at Arvind Eye Hospital, Madurai, and Dr. Anubha Rathi, who is an associate ophthalmologist at Shantilal Sanghvi Cornea Institute at LVPI, Hyderabad. Also, my special thanks goes to the three discussants, Dr. Shakeen Singh, who is professor and head at Dr. Sri Guru Ram Das Institute of Medical Sciences and Research Center at Amritsar, Professor Subina Narang, who is a professor at Government Medical College and Hospital, Chandigarh, and my dear friend, Dr. Rupesh Agrawal, who is an associate professor at Lee Kong Chian School of Medicine, Nanyang Technological University, Singapore, for consenting to be discussant. But unfortunately, today his flights are delayed and he might probably not be able to be with us. So without much ado, I would request the first presenter, Dr. Meghna Grandi, to share her screen. Just for the information of both the presenters, as well as the mentors, as well as the discussant, the postgraduate is supposed to present the article in 10 to 12 minutes. If you interrupt it while she's presenting, well, that will be considered those way. And the 20 minutes is going to be approximately the discussion per article. In the discussion, the mentor, as well as the mentor of the other article, as well as all the three discussants can discuss the article. The aim of this journal club is so that the postgraduate gets a message from this particular article. Second thing is how he should read through the article, or the reliability of it, the statistics part of it. If this is highlighted, that will be helpful to our postgraduate. So Dr. Meghna, please do share your screen.
Sir, are my slides visible, sir?
Yeah, make it in a presentation mode.
Yes, yes.
Fine, great. Go
Yes,
ahead.
sir. Yeah. A very good evening to one and all present here. Today, I'll be talking about the guidelines for treatment of no light perception eyes induced by mechanical ocular trauma. So severe mechanical ocular trauma with no light perception predicts a poor prognosis of visual acuity and enucleation of the eyeball. Since the innovative treatment concept of exploratory vitreoretinal surgery has developed and treatment technology has advanced, the outcomes of severe ocular trauma treatment in NLP patients have greatly improved. However, there remains a lack of unified standards for the determination, surgical indications, as well as timing of vitrectomy in NLP eye treatments. To address these problems, we aim to create evidence-based medical guidelines for the diagnosis, treatment, and prognosis of mechanical ocular trauma with NLP. So these are articles from an investigative ophthalmology and visual sciences which showed improvement in visual acuity in 6 patients and have concluded that in case of an open globe trauma with initial no PL, functional recovery is possible if there is no irreversible anatomical damage. And this is another article which showed 21 eyes out of 577, which showed improvement in the visual acuity. So we have 16 relevant recommendations to guide the treatment of mechanical ocular trauma. So this guideline was developed by Tianjin Medical University General Hospital, and the methodological support was provided by the Grading of Recommendation Assessment, Development and Evaluation China Center. This was registered in the International Practice Guideline Registration platforms, and these guidelines are applicable to all medical institutions that manage the treatment of mechanical ocular trauma with NLP. And the guideline users are ophthalmologists, and the primary target populations are patients diagnosed with NLP induced by mechanical ocular trauma. So the working groups on the guideline consisting of the committee of the editorial group and consensus consist of 53 experts, and a total of 60 ophthalmologists were surveyed, and the evidence collection was by PubMed, Embase, and the Cochrane Library. And this is the evaluation grading of evidence quality by Amster evaluation meta-analysis and Cochrane bias risk assessment. So coming to the clinical recommendations, we have to first ask about the history of ocular trauma as well as visual acuity. A darkroom examination and the other eye should be completely covered, and the light from the direct or indirect ophthalmoscope should be used to examine all the 9 directions. Lack of response across all sections would classify as NLP. The common causes of NLP will be discussed in clinical recommendation 2, which shows damage to the optic nerve as well as optic nerve contusions, extensive ocular tissue or tissue loss or severe damage to the ocular tissue in case of intraocular tissue prolapse, extensive damage to the retina or the choroid, and severe ciliary body damage. And associated severe media opacity due to corneal injury, traumatic cataracts, and dense intraocular hemorrhage and endophthalmitis. The prognostic risk factors for NLP eyes, the guideline development group determined the outcome indicators according to the ocular trauma score variables and provide a systematic review showing that eyeball rupture was the most important risk factor for prognosis. The incidence of low vision and PVR after vitrectomy is higher in ruptured eyes, and the incidence of endophthalmitis significantly increased in the presence of intraocular foreign body retention. The incidence of poor visual acuity prognosis and the possibility of long-term NLP were highest in patients with zone 3 injury, and the incidence of RD and enucleation after zone 3 injuries was the highest. If the length of the wound was greater than 10 millimeters, RD was most likely to occur. These are the other prognostic factors like severe ciliary body damage, intraocular hemorrhage, lens damage, and traumatic endophthalmitis, proliferative vitreoretinopathy. So the timing of primary surgery and vitrectomy has a significant impact on the prognosis of mechanical ocular trauma, and delay of primary surgery over 24 hours increases the risk of endophthalmitis. The risk of poor visual outcomes in RD was lower in patients who underwent vitrectomy 7 to 14 days after injury than those who underwent vitrectomy more than 14 days. And the lens injuries, which are caused by ocular trauma, can increase the incidence of poor visual prognosis as well as endophthalmitis. There is severe ciliary body injury and intraocular hemorrhage can also affect the prognosis of visual acuity as well as lead to abnormal intraocular pressure. So the clinical recommendation 4 discusses about the influence of intraocular foreign bodies. The intraocular foreign bodies can affect the visual recovery and lead to significantly higher incidence of endophthalmitis. The metallic intraocular foreign bodies are associated with increased incidence of NLP, among which iron IOFBs have more serious effect. Wooden IOFBs are more likely to cause endophthalmitis. And intraocular foreign bodies with a maximum size of more than 5 millimeters may affect the recovery of visual function and increase the incidence of NLPs. Multiple intraocular foreign bodies can also affect the prognosis of visual acuity. In addition, according to the existing data, the incidence of low vision, which is caused by sharp intraocular foreign bodies, will be lower than that caused by curved, angular, or irregular intraocular foreign bodies. Clinical recommendation 5 tells about the preoperative preparation for the primary operation. The medical history of the patient with NLP induced by mechanical ocular trauma should be collected in detail before the primary surgery, and the entire ophthalmic and systemic examination should be performed in time. Prophylactic antibiotics and tetanus antitoxins should be used to prevent any infections. And surgeons should communicate with the patients as well as their family members about the risks as well as postoperative complications related to the eye injury and as well as the surgery, and obtain informed consent before surgery. An operation should be performed by the attending physician or the resident under attending guidance. So for severe injuries, basically, vital signs should be examined first, followed by an ophthalmic examination. CT, MRI, and other examinations should be used to confirm potential injuries such as intraocular or intraorbital foreign bodies and orbital fractures. So tetanus toxins as well, tetanus antitoxin or immunoglobulin should be injected as soon as possible in patients with open globe injury to avoid the risk of severe infection. Systemic or intravitreal vancomycin combined with ceftazidime or cefepime in early treatment can reduce the incidence of post-traumatic endophthalmitis. And doctors have also proposed prophylactic intravitreal antibiotics should be used in following risks like 30 wounds, delay in primary surgery more than 24 hours, breach of the lens capsule, and retained intraocular foreign body. So systemic glucocorticoids as well as glucocorticoid eye drop treatment administered to patients in case of excessive choroidal prolapse during primary surgeries. So the primary operation, which is timing, anesthesia, as well as principles, suturing of the ocular wound should be performed within 24 hours in case of open globe injuries. Local anesthesia is generally used in primary surgeries, and general anesthesia can be considered in case of prolapses that are expected or in case of presence of severe injuries to other parts of the body. And appropriate methods should be selected to suture the wound according to different conditions to restore the intraocular tissue. A delay of primary surgery of more than 24 hours is associated with increased incidence of endophthalmitis. Therefore, timing of surgery is very, very important. It should be less than 24 hours is recommended. And most doctors usually choose local anesthesia to treat the wounds in zone 1 and 2 and for patients whose physical conditions do not allow general anesthesia or in emergencies when the treatment time is very urgent. So general anesthesia should be considered in case of large rupture wounds or those who cannot cooperate with local anesthesia due to systemic diseases. So the main purpose of primary surgery is to close the ocular wound, retain the eyeball, and restore the intraocular pressure. And for perforating wounds, anterior wounds should be sutured first, whereas posterior wounds are generally not sutured. And traumatic cataracts are recommended to be removed during vitrectomy. So preparation, the NLPIs should undergo detailed examinations before vitrectomy. Patients as well as their family members should be informed of the operative risks and the potential complications before surgery. Comprehensive surgical equipment and instruments should be prepared, and the operation should be performed by experienced doctors in the field of ocular trauma as well as vitreoretinal surgeries. Antibiotics are most commonly used to prevent endophthalmitis. And for patients with high IOP after primary surgery, topical eye drops, oral carbonic anhydrase inhibitors, or mannitol can be administered if necessary. And vitrectomy should be performed by an experienced ophthalmologist specializing in ocular trauma. So indications of vitrectomy. The most common indications are a vitreous hemorrhage, retinal detachment, massive choroidal detachment, intraocular foreign body, as well as endophthalmitis. So timing of vitrectomy. Currently, the timing is mainly divided into early surgery with less than 3 days, delayed surgery of 4 to 7 days, late surgery is 8 to 14 days, and very late surgery of more than 14 days. Vitrectomy is usually performed as early as possible to reduce the risk of endophthalmitis in patients with IOFBs or in case of high-risk infections. Early vitrectomy has a certain effect of preventing proliferation, and the indication is constricted, such as those without any corneal rupture or a large ocular wound. And suprachoroidal hemorrhage should be drained during vitrectomy. If vitrectomy cannot be done easily, bimanual manipulation can be adopted. So prevention and treatment of intraoperative complications. The prophylactic photocoagulation of cautery should be done around the intraocular foreign body before removal. And sufficient cautery should be performed at the appropriate site before retinotomy or retinectomy to prevent any bleeding. In case of intraoperative bleeding, an increased infusion pressure of cautery base must be conducted. And intraoperative bleeding is mainly caused because of inadequate cautery or accidental damage to the retinal vessels during the separation of the proliferative membrane, which is adherent to the retina or near the wound. So if there is intraoperative bleeding, hemosis is mainly achieved because of infusion pressure or cautery. And if there's a large or persistent bleeding, which results in a blurred media, the bleeding point can be accurately identified and air fluid exchange can be temporarily performed. And intraocular cautery should be used to stop the bleeding after intraoperative field is basically clear. The retinal tears, in case of they can be prevented by careful manipulation. The present retinal tears can be closed by laser photocoagulation or cryotherapy, and then silicone oil or inert gas is filled in the eye at the end of vitrectomy. Possible causes are basically because of the vitreous tractions when surgical instruments repeatedly pass in and out of the sclerotomy and peeling of the epiretinal membrane. According to results of meta-analysis, the incidence of iatrogenic retinal tears in vitrectomy is 11%. So when silicone oil goes into the retina, it can be removed by retinectomy or retinotomy at the appropriate site. And perfluorocarbon liquid that migrates into the subretinal space is mainly caused by inadequate removal of the epiretinal proliferation or incomplete retinotomy or retinectomy. So prevention and treatment of complications after vitrectomy. Corneal edema gradually recovers after treatment. Hyphema, if the amount of hyphema is large and the IOP is very high, removal should be done as early as possible. Cataracts caused by silicone oil tamponade, cataract extraction can be combined with oil removal. So vitreous retinal hemorrhages, bleeding can be prevented by thorough hemostasis during vitrectomies. Recurrent retinal or choroidal detachments, the iatrogenic retinal injury should be avoided and retinal and choroidal lesions should be treated thoroughly. In case of silicone oil dependent eyes, delayed oil removal of silicone oil reoperation to replace it should be done. In case of abnormal IOP, anti-glaucoma surgery is required if the drug cannot respond to control the secondary glaucoma. And traumatic endophthalmitis can be reduced by vitrectomy combined with silicone oil tamponade and intravitreal antibiotics. So clinical recommendation 11, choice of the intraocular tamponade. Silicone oil is recommended as the main intraocular tamponade for NLPIs, owing to its lower density and high surface tension than water. Inert gas or balanced salt solution can be used for minor retinal injuries. So globe salvage versus our enucleation. So enucleation of the eyeball is basically not recommended in emergency surgeries unless almost all our intraocular tissues are lost. And the possibility of enucleation of traumatic eyes after the primary operation cannot be ruled out when there are severe complications such as sympathetic ophthalmia, long-term eye pain, or eyeball atrophy, or phthisis bulbi, and if the possibility of restoring light perception is lost. If enucleation is inevitable, ophthalmologists should fully communicate with patients and their family members and provide psychological counseling to relieve the patient's anxiety. So enucleation can be considered as a primary operation and if the affected eye has NLP even before ocular trauma. The criteria and prognosis of silicone oil dependent eyes. The criteria is basically limited potential for visual recovery or recurrent RRG after silicone oil removal. This is a persistent low IOP resulting in phthisis, and if there's a functional monocular patient. Long-term silicone oil tamponade effectively maintains the IOP, but there are certain complications associated with like silicone oil emulsification, secondary glaucoma, cataracts, and corneal degeneration. Silicone oil should be removed within 3 to 6 months after vitrectomy. The follow-up precautions after vitrectomies, routine follow-up should be performed with 1 week at 1, 3, 6, and 12 months after vitrectomy. And visual acuity, IOP, and as ocular structure should be examined during follow-up. And all the complications should be treated on time. So visual outcomes and recovery, the final acuity of the NLPI should be induced by mechanical ocular trauma has the potential to improve after vitrectomy, and the rate of vision recovery gradually increase after vitrectomy. Meta-analysis showed that visual acuity was restored to light perception and hand movements in 34% of the eyes with NLP after vitrectomy, and to counting fingers in 16% of the patients, and better than 20 by 411%. Subgroup analysis showed that light perception recovery rate gradually increased until 1 year after vitrectomy. And effectiveness of corticosteroids, the use of triamcinolone acetonide or dexamethasone after primary surgery is recommended as a single intravitreal drug therapy for empirical anti-inflammatory therapies. So for patients with NLP induced with mechanical ocular trauma, vancomycin is recommended as a single intravitreal drug for empirical anti-infective therapy. And concomitant medicine with vancomycin is also recommended based on the outcomes of pathogen culture and antimicrobial susceptibility testing. Voriconazole and amphotericin have been recommended for the treatment of fungal infection. Thank you. I thank Naresh sir for giving me this opportunity to present this webinar. And I thank Muthukrishnan sir for helping me and guiding me through the meeting. Thank you, sir.
So Meghna very well presented. Now I request all the discussion, Dr. Rupesh, thank you for being with us in spite of your tight schedule. Thank you, Professor Shakin Singh sir also welcome. Dr. Rubina, you can join the discussion now.
Sure. Dr. Meghna, this is Dr. Rupesh here, very well presented. Can you go back to the first or second slide, the research question, because this is Journal Club, right?
Yes.
So let's just go back to the first or second slide, and then the methodology. The first slide or second slide where there was a research question. Okay, evidence-based medicine. And okay, next slide. This is background. So go back to the previous slide, the 16, the next slide. Yeah. So guidelines for the treatment of no light perception induced by mechanical ocular trauma. 16 relevant recommendation to guide the treatment of mechanical ocular trauma associated with NLP. So you are presenting about this journal, okay?
Yes, sir.
Correct?
Yes, sir.
I am trying to see where is this journal article published?
When is
you tell them. No, you just tell me. Is this? So that's something, one fundamental thing. Whenever you present, at the bottom footnotes, it should say this is published in BGO 2019, because this article can be published in 2002 or 1999. I don't know whether it is 2019, though I've read the paper. That's number one. There is no mention anywhere about different, throughout the slides you presented, there is completely missing a link to the references you're talking about. Okay. Everywhere, because this is not your work. Very much like when we write a paper, very important thing is that you need to cite the papers where it is coming from, number one. Number two, while you presenting, I was completely lost in thinking whether you or what the authors have done. And see, first of all, you have to come up with the last two slides would be your strengths of the paper and the limitation of the paper, any paper. So you tell me now, you read the paper, what is the strength of the paper and what is the limitation of the paper? What are the limitations of the paper?
The problem isn't regarding the application all over the world, sir, regarding.
So I'll tell you, see, they wanted to set up a meta-analysis of the paper. So there are few types of review article. One is a narrative review article. One is a systematic review meta-analysis. Then third is the Cochrane review. So when you go for an Oxford level of evidence, because you want to set up an Oxford level of evidence, the level of evidence for a systematic review meta-analysis is better, then Cochrane review is even more better. So you can read into the Oxford level of evidence level 1, 2, 3, 4, 5, the narrative review. Now, I'm completely confused whether this is a systematic review meta-analysis or is it a narrative review, or is it an expert opinion? Because there are so many of these recommendations which feel like consent to be taken. Was that a recommendation by the meta-analysis where 16 studies analyze whether the consent to be taken or not. So that is just one example I'm giving. What I don't know, what is this study recommended? I wanted to know and what was the basis and rationale and confidence interval for those study to be done. So if I have to say a patient need to undergo a enucleation, I will say 16 or 14 out of 16 studies recommended primary enucleation with the confidence interval of 0.95 to 1.1 with a p-value of 0.005 and with the odds ratio of this. You have to produce that thing so that I know this is something. Now, when you say confidence interval, and if your confidence interval become like 0.5 to 3.0, that does not become anything statistically significant. So throughout the article, I was waiting that you will be presenting about the statistics done and you will be criticizing about it. So something you should present about it and you should at the same time criticize. So throughout the article, I was thinking, is it Professor Huayan or Professor Ferencun or Professor Zhirong Meng? They are writing their own experience driven. So that is what which is currently available in the literature. A lot of people write what they think, but this is far, far, far away from the evidence-based medicine. Evidence-based medicine based on the original studies. And that too, we have to critically see out of these 16 studies. If you look into my paper published in BMC Ophthalmology on no light perception in 2013, we have performed a study of that original studies. So you have to get those studies there, similar studies, and then do a meta-analysis of it and then present about it, and then it becomes a real evidence base. We are trying to work on a Cochrane review of no light perception with Cochrane Group in UK. It's been 3 years. We are to and fro. Probably 1,000 over emails have been exchanged. We not yet been confirmed the protocol approved by the Cochrane Review Board. And we have around 65 authors in that, just trying to establish the Cochrane guidelines for that. So meta-analysis, we are trying to write meta-analysis. One meta-analysis, it takes at least 2 years of work. And the review article, you can write it in 1 week, but that does not form the evidence. That is just your experience. So something for you to consider when you go back, think about it. And if I'm happy to kind of review your slides again, I can share my email. Dr. Naresh Babu has my email. And even you can WhatsApp me and send me the slides with what you think about this paper. And then how do you improve upon this particular paper and make it even more better paper when you do a study? Because something which you need to learn is the data, all the data being collected. I can't imagine those many data being collected by different people. It's impossible for retrospective study. So many data points are missing. You need to come up, the data analysis was lacking, data points were missing, systematic, the p-value was missing, the confidence interval were missing, the results were not analyzed properly. And therefore, the take-home points from here becomes very limited. Okay. So with that, those were my few comments, and maybe Dr. Shakin Singh and Dr. Subin.
Yeah, Dr. Subina, please. You're muted, ma'am. You're muted, Dr. Subina.
Oh, hi.
Yeah.
Can you hear me now? Yeah.
Yes. Yeah.
I would say, yes, she's done a lot of hard work in reading and putting all this article in place. But the first thing is methodology has to be dealt with. Once you're presenting a journal club, tell how this data, like Dr. Agarwal said very nicely, that it is, you have to tell the good points about the study, the bad points. And the basic thing is the methodology is the key to a paper. You have not mentioned about it, the grade analysis, like they are forming a guidelines. So they are set guidelines, there are methods of doing it. So you have to come out with that, right? But what I didn't like about this paper was that they also gave a questionnaire to the patients. And I think there was 100 patients here and they did give the questionnaire, and then they were also a part of it. I don't know whether that makes it evidence-based, because any patient with no light perception would always hope that he's going to be getting vision. So he cannot be a part of forming the guidelines. They're like, patient always wants it to be, okay, this should be done. Like they said, you should go ahead with doing full vitrectomy, silicone oil, patient is no light perception. Even after that, removal of silicone oil, if it's emulsified, and re-injection also. So I think it's just expert opinion. And once they are putting recommendations, they are not, for everything, they are not saying whether it's a strong recommendation or a recommendation, what kind of recommendation it is. Because in the beginning, they say they'll be grading the recommendation, whether it's strong or it's weak. But in the paper, they've lost it somewhere. It doesn't come out as strong recommendation for this. I mean, you have to find what kind of recommendation they are telling. So I don't know.
Sorry, just like to make one more comment after Dr. Narang has said the survey thing. So when you do a good survey study, and I see a lot of email coming to me for survey study, the survey itself does not form guidelines. So that is a very, very low level of evidence. Survey, you need to do a study, something like a Delphi study or something, and that's where you form. Because surveys, I can roll out 50 questions, whatever, but a steering committee need to be set up who ratify this question, and you need to evaluate those questions. Again, go through the different rounds of survey and do it in a very systematic way for survey to form and establish as a guideline. So a lot of times people just do one survey and then we write a title as a guideline. Those are not the guidelines. Survey are the lowest level of evidence of anything. Yeah. Sorry, Dr. Naran, I thought I just.
Dr. Shakeen.
Oh, that's
Already enough has been explained by Dr. Agarwal and Dr. Savina. So if you talk of the guidelines, first of all, I would say, sorry, I was there busy in theatre, I just finished. Unfortunately, the case I've just finished is in enucleation, which was not repairable. So this guideline, what I see is consent of the patient. They are not talked anything about the consent of the patients, and then the medical legal issue of the patient. So if we are going to give the guidelines, the guideline has to include inclusive of everything. Like now, in this case, I was prepared for primary repair, though there was no NLP. But on the side, I saw that scene was totally different. So otherwise, I really congratulate Dr. Meghna Gandhi. She has really, gone through the paper, whatever it is, the way it was. So it was a really good presentation on his part. But definitely, we need to review the paper.
Yes, Dr. Anubha
Thank
is
you.
also there, the mentor of the other article. Dr. Naresh, you can also add to it, please. You are muted, Naresh.
Yeah, apart from this article, sometimes we cannot have a proper guideline for cases like this because I think they have used Delphi also in this. And
Yeah.
not many people are also doing this sort of work throughout the world. So maybe I think we can take something from this. But there are certain good things also in this article regarding the what do you call the timing of the surgery, the indications, the counseling, all those things actually. But yeah, a few good things can be taken from this article.
Anubha?
What I wanted to propose here is if AI is not Dr. Bhawankul is here, and this is a very important topic, and I do know my incomplete job, which Dr. Bhawankul has said about creating a consent form for a trauma patient. He has put up 2-3 times in the trauma group, but I could not complete that job. What I was thinking, if Dr. Meghna wants to take it up, he can do a study for AIOS, which I'm happy to mentor her along with Dr. Naresh. And there is another Dr. Richard Blanche from UK who's been interested and he's been asking me. It's just that my plate was quite full. But if you want to take it up, we can design through AI as a very nice Delphi guidelines, and where we will engage proper Delphi experts, and where I'll take Dr. Meghna through how to do a nicely Delphi study, and we'll bring in and and we can also parallelly we can do a systematic review meta-analysis, because both study design, both methodology are quite different, but can be done both. And if Dr. Naresh is okay and Dr. Meghna
That's
is
right.
okay, we can then mentor, and the study can be completed under the banner of AIOS if Dr. Bhawankul sir and Dr. Sakin sir.
They are
and
always
Dr.
there.
So
Yeah,
definitely.
shall we do that? Yeah, that will be nice, right, sir? Because this is quite important topic.
Exactly. Yeah.
Dr. Anubha, your comments, please, on this paper.
Yeah, thank you, Dr. Prashant. So I think I agree with most of the comments which have been already, spoken. And good job, Meghna. Just that I think this JC could have been presented a little more like a JC. It was a lot of guidelines were being spoken. So I think we could have maybe studied the methodology in detail, and then all these points you only yourself would have come up. So the most of the points that have been discussed are pointing that whenever you have to develop a guideline, a stronger level of evidence is required. So I think I totally agree with that, and it's a good idea that if AIOS takes that. Because I think in India we have actually, I can't say privilege because for the patient it's not good, but we actually see so many such patients. So if we do not develop the guideline across for the world, I don't think any other country.
Thank you. Thank you. Thank you. That was a wonderful discussion, I believe. And Meghna, I should congratulate you. In fact, she is just a third-year resident, but her confidence with the way she presented, we all should laud her. Probably at her age, we would have been seriously much more nervous than what the confidence which she presented. So congratulations to you and well done.
Thank
And
you.
of course, to her proud mentor, Dr. Naresh Babu, for making her go through and helping her prepare through. So, well, now let's move on to the next article. It would be by Dr. Anirudh Herur from LV Prasad, and his mentor is going to be Dr. Anubha.
Good evening, sir. Is my screen visible?
Yeah, make it presentation mode.
Yeah. Yeah. Is it visible?
No,
Not visible.
it's
Vis-
visible, but it's not in the presentation mode.
No.
No, no, go to the bottom right, and then there should be a presenter mode. You want to give it a try. Because still there is a notes.
Oh,
Now the
that's
bottom right.
That's
Correct,
okay.
correct. That's it.
Now better. Yeah.
Okay. My voice is audible, right?
Yeah, Anirudh, you are well audible.
Okay. Very good evening to one and all. My name is Anirudh Herur, and I'll be presenting the second journal for today. And the moderator for this session will be Dr. Anubha Rathi. At the outset, I would like to thank Dr. Prashant and the entire ARC team for giving me this opportunity. And I apologize for my voice. I've been down with a cold for the last 2 days. So before we begin, I'm sure that all of us have seen this flowchart millions of times, but revision always helps. So the Birmingham Eye Trauma Terminology System, or the BET system, essentially classifies ocular trauma into closed globe and open globe injuries. In today's article, we'll be focusing mainly on open globe injuries, which are classified into laceration and rupture. And laceration is further classified into penetrating injuries, perforating injuries, and an intraocular foreign body. Now, it's essential and very important to know the magnitude of the problem that we have. So, nearly 500,000 cases worldwide annually suffer from ocular trauma, suffer from blindness because of ocular trauma. A 2016 study that was conducted by Batur et al. Showed that the annual incidence of open globe injury in the United States was 0.038%. But when we come to India, both the Arvind Comprehensive Eye Study and the Andhra Pradesh Eye Disease Study conducted by LV Prasad showed an incidence of ocular trauma to be 4.5 to 7.5%. And what's more is that of all the ocular trauma cases, 27 to 65% present with traumatic cataracts. Now, given all of this, I present to you the article that I'm going to present today, Visual Outcomes of Open Globe Injury Patients with Traumatic Cataracts by Rodrigues et al. This was published in International Ophthalmology with an impact factor of 2.029. Sorry. So now, as residents manning the emergency departments, I'm sure that all of us have seen a lot of open globe injury patients. And the primary thing that goes through our minds when we see an open globe injury patient with a traumatic cataract is when the patient is going to get operated, are we going to extract the cataract or not immediately, or will this require a delayed cataract extraction, and what is going to be the effect on visual acuity? Moreover, I'm sure we've all been asked this question that, doctor, will I get my vision back, or what is going to be the outcome? So do we know the prognostic factors that are associated with open globe injuries? So we believe that this article at least attempts to answer the above questions, and hence we chose this article. So the objectives of the article are to investigate the relationship between visual outcomes and traumatic cataract in open globe injury patients, and to investigate if the timing of cataract extraction can predict poor visual outcomes. So this was a retrospective review conducted at the Harris Health Bentop Hospital in Houston, in the United States of America, from January 2014 to December 2018. So what they essentially did was divide the methodology into data collection and statistical analysis. And in data collection, the first thing is the selection criteria. So they fired up their electronic medical records and did a comprehensive chart review of all patients who presented to the emergency department of the above mentioned hospital with open globe injury in the aforementioned duration. However, they excluded those patients in which there was a prior eye surgery or a pre-existing ocular pathology, essentially anything that could affect the visual acuity. And they also excluded patients who did not have a sufficient follow-up period. That is a follow-up period of less than 1 month after the open globe repair. Now, they did an exhaustive collection of emergency room documentation, pre and post-operative notes and the treatment course, follow-up data, and also the specialty of attending physicians overseeing the residents. When it comes to data collection of the patients themselves, they collected both the systemic comorbidities and the ocular. In systemic, they noted if the patient had diabetes, chronic obstructive pulmonary disease, coronary artery disease, or ethanol dependence. In the ocular part, they had both the preoperative and the postoperative variables. In the preoperative one, they essentially looked at everything that you would see in an open globe injury patient, like scleral lacerations, corneal lacerations, lens damage, hyphema and intraocular foreign bodies. And postoperatively, they looked at retinal detachment and endophthalmitis. So they essentially divided all the patients that had open globe injuries into those with traumatic cataract and without traumatic cataract. And those with traumatic cataract were further divided into those who underwent a primary extraction of cataract versus those who underwent a delayed extraction. So the visual acuity was recorded at the first visit and the last follow-up visit. They classified the visual acuity according to the ocular trauma score into the above 5 categories. And a poor visual acuity was denoted to be less than 20/200, which is the United States cutoff for legal blindness. Now, what I found really interesting was that all surgeries were performed by residents under the supervision of attending physicians. And these attending physicians, as mentioned earlier, were further divided into retina and non-retina specialists. So now coming to the statistical analysis, they first conducted a univariate analysis in which categorical variables were analyzed using a Fisher's exact test and continuous variables were analyzed using the independent sample t-test. Now, all the factors that were significant on univariate analysis, significance meaning they had a p-value as defined by them to be less than 0.1, or the factors that had a known clinical significance underwent a multivariate logistic regression analysis. And they used an IBM statistical the IBM SPSS version 26 and the SATA version 16.1. And similar methods were used to identify the outcomes for the timing of cataract extraction, which was their secondary outcome. Now, finally, coming to the results. So they had a total of 102 patients, of whom 64 or 62.8% had traumatic cataract and the remaining were without traumatic cataract. Now, as you can see here, the gender, give me just a minute. Yeah. So the gender, the age, both of them did not have a significant difference or a significant association with the presence or absence of traumatic cataract. However, the duration of the open globe injury repair to the last follow-up visit, that is the entire stay after the open globe repair till the patient was there in the hospital, was significantly different between traumatic cataract patients and those without traumatic cataract. The next slide talks about the lens capsule. So as expected, patients with traumatic cataract had a violated lens capsule, nearly 54.7% patients. Only one patient with traumatic cataract had a non-violated lens capsule, but a large chunk, nearly 28 or 43.8%, had an unknown lens capsule status. In without traumatic cataract, as expected, only 2 had violated lens capsule, which was nearly 20 had a non-violated lens capsule, and in 16, with the lens capsule status was not known. So only 18 patients out of 64 underwent secondary intraocular lens placement, of which 12.5 are the most number, or 8 patients underwent scleral fixation. And capsular bag and sulcus was the preferred site in the remaining half. So 5 patients underwent capsular bag fixation of the IOL, and 5 patients there was a sulcus implanted IOL. Now, when we come to this rather busy looking result slide, we see firsthand that a poor preoperative visual acuity and a hyphema and the case of traumatic cataracts being operated or supervised by retina attending is more significant in patients with traumatic cataract as opposed to patients without traumatic cataract. But when we see the other factors, we also see that in retinal detachment, the number of patients with retinal detachment is much more in patients with traumatic cataract compared to that, although the number is not significant. In corneal laceration, the number is, when on eyeballing the figures, the number is almost the same. And even in case of intraocular foreign body, we see that the number of patients with traumatic cataract having an intraocular foreign body is much more than those without. And even here, on univariate analysis, it is not significant. Furthermore, it is seen that patients with traumatic cataracts were more likely to get one or more retinal surgeries. And on univariate analysis, they were more likely to have a poor final visual acuity. Now, they also looked at what other factors were more likely to have one or more retinal surgeries, and intuitively we can say that retinal detachment and removal of foreign body were associated with it. But interestingly, female gender was another factor that was more likely to undergo one or more retinal surgeries, apart from diabetes. Now, on multivariate analysis, it was seen that 3 factors, retinal detachment, scleral laceration, and hyphema, were significantly associated with a poor final visual acuity. But traumatic cataract was not. Traumatic cataract had a p-value of just 0.386 and was not significantly associated, along with corneal laceration, poor preoperative visual acuity, and the presence of a retina attending. Now, coming to the second outcome, the primary versus delayed cataract extraction. So 41 patients underwent cataract surgery, of which 15 or 36.6 underwent primary extraction, and the remaining 26 underwent delayed extraction. So here, neither the gender, the age, or the duration of OGI repair to the last follow-up visit was significant. And only 2 factors turned up to be significant on univariate analysis. That was basically all patients that was the presence of a retina attending and the removal of a foreign body. And again, on univariate analysis, poor final visual acuity was associated with primary extraction as opposed to delayed extraction. But like earlier, this did not turn up on multivariate analysis. So most of the literature focuses on the outcomes between open versus closed globe injuries, or the effect of primary or delayed cataract extraction in pediatric patients. So as we've seen in this study, that while univariate analysis did show an association with poor final visual acuity, multivariate did not. And in a study by Agarwal et al., which focused primarily on zone 3 injuries, here too, it was seen that there was an association between traumatic cataract and poor final visual prognosis on univariate analysis. But interestingly, that too did not show up when they did the multivariate analysis. So this was in parallel, or this mirrored our study. Another interesting thing that they brought up in the discussion was that we would think intuitively that a poor preoperative visual acuity would be associated with a poor postoperative visual acuity. And that is what they tried to explain, because in their study, a poor preoperative visual acuity was not a prognostic variable for final visual acuity. So what they attempted, the way that they try to explain it is that they say that they have a small sample size, which might be one of the reasons. And the other one could be it's actually a true finding. Because a poor preoperative visual acuity can be because of multiple reasons, can be because of retinal detachment, can be because of corneal laceration, scleral laceration. So it could be that when we are looking at traumatic cataracts per se, it might be that it is not a prognostic variable for final visual acuity. Because there are certain factors like a traumatic cataract which are treatable and have a better prognosis, as opposed to certain factors like retinal detachment which have a poorer prognosis. Now, when we come to primary versus delayed cataract extraction, Sen et al. Analyzed 139 eyes of pediatric patients, and they saw that even in pediatric patients, there was no significant difference in visual acuity outcomes between primary versus delayed. And Tabatabai et al., they analyzed 60 eyes of patients between 12 to 69 years of age. And here too, they saw that there was no significant difference between the timing between primary and delayed cataract extraction. And lastly, looking at the presence of a vitreoretinal specialist. In a study by Hahn et al., the presence of VR surgeons did result in significant improvement in visual outcomes, whereas in this study on multivariate analysis, it did not show any effect. But an important point to note here was that all of the surgeries were done by residents and were supervised by a retina attending. So that could be a potential confounding variable there. So coming to the limitations, the obvious limitation is that it is a retrospective design. And given that the age and demographics of not only one state in the United States, but everywhere in the world is different, it is difficult to generalize the outcomes. They've admitted that they've not documented the morphology of the cataract, and the status of the lens capsule was not sufficiently documented. And also, nearly 97% of the patients visited the hospital the first time when they had the open globe injury. So there was no data whatsoever on any pre-existing ocular or systemic conditions that could play a role in the final visual acuity. So all in all, results of this study could help in counseling patients with traumatic cataracts as regards to the treatment outcomes, and could also help in explaining the possible need for retinal surgeries. So when we come to the MARI analysis, I'll quickly run through it. So there was no hypothesis per se that was declared, but the purpose of the study, as has been iterated multiple times, is to study the effect of traumatic cataract on visual outcomes in OGI. The population was appropriately defined, as was the inclusion-exclusion criteria. And being a retrospective study, there was no defined sample size. Now, individuals were assigned to two groups based on the presence or absence of traumatic cataract. While some confounders were accounted for by the multivariate analysis, there were a few that were not accounted for, like the level of expertise in terms of residency. Like, was it a first-year resident, a final-year resident, that could play a potential that would play a potential role on the poor final visual acuity. The zone, one of the most important factors that we felt was, even though they had initially classified the visual acuity as per the OTS, the zone of injury was not documented, and open globe injuries were not further subclassified as per the Betz criteria. As stated earlier, the lens capsule status and morphology was not available, which could play a potential role, in the extent and repair and details of the corneal and scleral laceration were not mentioned. The outcome measures do address the study question appropriately. However, considering that traumatic cataract surgery is in itself a complicated surgery, there was no documentation of intraoperative complications, if any. Secondly, while they do compare primary versus delayed, how delayed is delayed was not mentioned. The duration after which the cataract was extracted was not mentioned. The intraocular lens type was not mentioned, and details of additive vitreoretinal surgeries or others, if any, was not defined. However, the follow-up was complete, and the patient's knowledge of the study likely did not affect the outcomes. We estimate that the traumatic cataract did have a significant effect on visual outcomes in univariate, whereas in multivariate it did not hold true. And while appropriate statistical methods were used for analysis, one thought that came across our mind was, considering that the sample size was more than 20, was nearly 64, would it have been better if they had used a chi-square test instead of a Fisher test? And lastly, for adjustment, multivariate analysis did account for a few confounding variables. As mentioned before, results can help in counseling patients with regards to treatment outcomes and need for multiple surgeries. Considering that it was a retrospective study, no adverse effects or interactions, and the last one is not applicable. Now, before I go on to the extrapolation, I just wanted to get this checklist out there. So there's a really interesting book that we would recommend for all residents to read called Clinical Epidemiology, A Basic Science for Clinical Medicine by David Sackett. So what it gives is a really succinct and brief overview of how to clinically appraise, or basically criteria for journal appraisal. And so it has multiple categories in which you can classify your journal. We thought that our journal fit into the therapy category. And amongst the checklist, as you can see on the screen, I'll quickly run through them. Was the assignment really randomized? And no here, obviously. Clinically important points were assessed objectively. This treatment is feasible to use in our practice. They had a really good follow-up, and yes, both statistical and clinical significance were considered. And lastly, while traumatic cataract is likely to play a role in open globe injuries, the decision we feel for primary versus delayed cataract extraction still remains clinical. Thank you.
Very well presented, Anirudh. I welcome Dr. Muralidhar. I see him on the participant panel. Please do join us for the discussion, sir. And we have our IRC member, Dr. Anaga, who is also predominantly an anti-segment cataract surgeon. So she will also join us for the discussion, Abby. Please.
Sure. Rupesh here.
Yeah, Rupesh, please.
Yeah, some points. So Anirudh, very well done. And I really impressed with this MARI analysis and some of the things which you brought up in the checklist, particularly, which I really like. But if you go to your third slide where you return retrospective review, do you consider this study design as a retrospective review study? Is it really the review study? So I think, yeah, so it's not a review.
Yes, sir. Yes, sir.
Yeah, so that's probably a typo or something.
Yes.
It's either the authors, because sometimes so it is good, maybe one of the classes we should have what are the different types of study, and
Yes.
this is not really a retrospective review. Next.
Yeah, it was a chart review.
Chart review. So chart review or retrospective cohort study.
Correct.
Next.
Yes.
So when you presented about the data collection, so that's so a lot of times we do that. Yeah, next slide after this. So a lot of times when we present, or the people, I've seen my colleagues and residents also do that. It is a chart review from the data points. But after this, the next slide when you present it, I was a bit confused whether, and you have lots of strong points. So what because of the paucity of time, I'm just highlighting certain points which I believe will help you in improvement of presentation and interpretation of a journal. The next slide. When you presented, next one. Yeah. When you presented, it was looking like these are the data points being collected. So this, like, it was ongoing, like a prospective study. Oh,
Okay.
they collected this laceration, they collected corneal laceration, they collected lens damage. No, so you are doing a retrospective chart analysis, and in which the variables which you considered in the variables which the authors considered in their chart extraction, right? So
Yes,
that's different from a prospective study. But when you present it, it was sounding like, or I don't know, I've not read the article, but it's sounding like as if, and a lot of people make that. So this becomes like a continuous tense which is present, but you have to present the paper in a past tense form.
Yes, sir.
Okay.
Yes, sir. Yeah.
Now the next slide about the univariate. Though I really liked it, but just for a lot of people, and here I have a little bit of a problem, which I'll say. So before univariate analysis, maybe you could have said the first thing is I always divide the statistics into two simple things. Descriptive statistics and analytical statistics. In the descriptive statistics, your table 1 come, which is the core of any paper, is a simple description of anything. And after that, you go into a univariate analysis. What I could not understand is the rationale for taking p-value of 0.1. Maybe
Yes,
I don't know what was their rationale, and I thought you will come up in the Mary analysis about that. But
Yes, sir.
maybe they had some rationale of taking 0.1, but that was one thing. Multivariate was okay. So I think overall everything else you presented. There is one thing which I think you should have pointed out besides mentioning about the complications. So I think they also missed out on zonulolysis, which I think I could not see that, and which also can play a very important role when the traumatic cataract outcome is concerned. The second thing you mentioned about the traumatic cataract operation done, and but there is no subgroup analysis in the patients. So you have said about the delayed versus the primary outcome. But if within the traumatic cataract group, if there was a subgroup analysis of those who underwent surgery, irrespective of delayed or primary, versus those patients who never underwent surgery.
Yes,
So I think
yes.
41 out of 64 patients underwent surgery.
Yeah.
Then another 23 never underwent surgery. So 41 versus 23. And within 41 would have been the two subgroups of primary and the delayed. Okay. And you mentioned a very interesting point about how delay is the delay. I will even go on to say how delayed is the primary, how early is the primary.
Yeah.
Because I hope a lot of you will get the point. Sometimes the patient comes late. Sometimes even if the patient comes late, there are centers whom I know who operate very late. So that also can affect the outcome, right, Anirudh?
Yes, sir. Absolutely.
So
Yeah. Yes, sir.
those are some of my points, and I am sure there are a lot of other points, but those I thought will add to further analysis of any of this thing. Yeah,
Yes,
I'm
sir.
sure there are other people to add. Yeah, Anirudh?
Yes, sir. Absolutely, sir. Thank you.
Okay, thanks.
Professor Shakeen, you can unshare the screen, Anirudh.
Okay. Yeah.
I think Anaga, you can add.
Yeah.
Shakeen is back.
Sure,
Shakeen,
Dr. Shakeen, sir. Yeah.
I think.
Dr. Shakeen, sir, your inputs, please.
Naresh Babu, you can add to it.
Dr. Subina, Dr. Naresh, sir.
I would say most of the points are very well covered by both Dr. Rupesh as well as the presenter himself. He's really done a very good job. And I think, yeah, there are retrospective analysis, and probably it is the most of the points, they are not very well told about the IOL which they put, the kind of traumatic cataract. And I think it has been well covered by the presenter himself. So that's nice.
Thank you, man.
Yeah, Shakin sir.
Sorry, there was a drain. In fact, from my point of view, he has really at his stage is very well covered paper. Maybe expert like Dr. Rupesh can find so many things, but I must congratulate him. He's really done a wonderful job. Thank you, sir.
Dr. Naresh.
Nothing, sir, nothing to add.
Hmm? Okay. So Dr. Muralidhar is there with us. Can he just have few points over in any of the presentations? Okay. He said he's in a parallel meeting. If possible, he will come in. Okay, no issues. Anaga, please. You are
Yeah.
a good cataract surgeon here. Your comments.
No, I think it was very well presented. All the points have been covered very well and in detail, and all the other points regarding the limitations of the study and as well as what were the deficiencies also have been pointed out. So I think it was very good analysis, and I really congratulate Dr. Anirudh and Dr. Anubha ma'am, and even Dr. Meghna and the mentors for taking the effort and their valuable time for going through these studies and presenting it in such a beautiful manner. I think it's going to be really helpful to all the postgraduates. And thank you very much to all the discussants also, Dr. Shakeen Singh sir, Dr. Subina ma'am, and Dr. Agarwal sir. Thank you so much.
Thank you. Thank you, everyone. Frankly speaking, we had a very nice, fruitful discussion. The whole aim of our journal club is that the young students, residents get exposed, because unfortunately, the journal club is losing the presence in most of the medical colleges in our country. And that's why we are trying to revive this particular art of presenting a journal. I'm really thankful to both Naresh Babu and Dr. Anubha and Dr. Muralidhar for mentoring these students to get into and making them so confident. They spoke like almost like a professional speakers, both of them, Meghna as well as Anirudh. So I should congratulate both the mentors. And Rupesh, he's a younger brother of mine. I'm so happy he's in transit and still he's found some time for us. I'm really thankful to him once more. And of course, my sincere most thank to Shakeen and Dr. Subina for being with us for our students and helping them out in learning this journal club. And so I think it's time for us to say bye-bye. We will be meeting on the following Thursday again with some other activity of ours. Till then, I think we should say bye. Let's thank Anaga
Yes,
on
yes,
ARC.
yes, yes. Thank you so much, everyone.